So thank you, Dr. Azad, and thank you everybody here for working with vision of babies. I'm not going to show some exotic cases. I'm going to show in our day-to-day practice, because when I started learning what happened, and some of these cases are from my earlier days, and then slowly we'll learn. So, this is just to show this pretty baby. She was our 10,000th baby and came with stage 5, and today she has 2400 vision in both eyes. We operated her immediately. So one of the things I found was Avastin allergy. So this baby we had injected in both eyes Avastin for whatever reason and came back with Avastin allergy. The whole face became red. And I have seen this in 2 adult patients. It's not common, but if you have something like this, then you always wonder, can I give another injection if they have a recurrence? So this is something rare. And we just treated it with the cream, and I sent to pediatrician. They will not get mucous membrane allergy. They only get dermal allergy. So the conjunctiva will not show allergy, but the skin around it, you can see whole of the face and skin is affected, and they lose their eyelashes and then it comes back. So the other thing is, this was my learning curve. This was way back before even AP-ROP was described. This was in 1999, just within 6 months of my starting ROP work. And I saw this child, the first photograph. This has also been published in IGO. And I saw this and I said, like what some Parijat showed, there's some dilated vessels but no ROP. But I was disturbed, and the night I called Lingam Gopal, who was still in Chennai, and said, I have this baby with no ROP but very abnormal looking box-like vessels. So he said, oh, this is rush disease, you must go and call back that patient and treat it. And I called back after 4-5 days, and in that 5 days the flat new vessels had come. And I treated it with aggressive treatment, then Dr. Gopal did surgery. Today this child is blind of stage 5. We could not salvage that eye. Then I went back and said, what went wrong? And obviously what went wrong was that we didn't detect the disease on time. And secondly, we were not aware that we have to laser all these areas. Because the angiograms actually show that these are avascular retinas. But I didn't have an angiogram, but now I know. I can clinically pick up these areas, and actually the more late the baby comes after AP-ROP, the more posterior is your ridge, because the retina starts growing. And you have to find these avascular pockets, which you can clinically pick them up. They are round, they are surrounded by vessels, and you have to go back and treat all of them, and you may have to treat right up till here, right up to the disc. So it goes back. You have to find the original ridge where the disease starts in AP-ROP, and then you can salvage, and that's what we publish in American Journal. You can get 88 to 90% laser outcomes in these babies if you find the original ridge, and provided they came little early. The second lesson we also learned from this baby was that the baby looked sick, and the mother didn't come for follow-ups because she said every time you treat the baby goes home with cough and cold. So actually it was the other way around. The baby is having cough and cold, and that is not allowing your retina to work, because there's a very close linkage between the lung maturity and the ROP. And again, in both VEGF is required. And you will see this, that the child who is not gaining weight, or child who is on prolonged oxygen, even who is not on oxygen but is having grunting, they don't work well. And Anand has shown, and we've also seen, the anemia is another factor. So the moment we see AP-ROP, we do the first sitting of treatment, whatever it is, laser, Avastin or whatever, and the same day we send for a hemogram, and we ensure that the hemoglobin is at least 10 and the RBCs are normal level, which is 3.5 lakh per cubic millimeter. Because if you don't address that anemia, you may do a lot of laser and then you'll say laser is not working. It doesn't work if the patient is anemic, and that's a whole topic itself. So this is one thing that people miss, and this we see very common. It looks like everything is fine, and you just miss that small area of new vessels developing. So what I tell people is, don't worry about it's zone 1 or zone 2. Look at the pattern of the vessels. Normal vessels should be dichotomously branching, dichotomously branching, dichotomously branching. If at any time you see that the vessel is not branching, so here you see they're dichotomously branching, and then suddenly something is happening. Suddenly they're forming some loops. This is where the AP-ROP starts. The journals and books don't show us when the AP-ROP starts and how it starts. They only show the advanced condition where there is traction in new vessels. But I am showing you 2 pictures, the first one and this one, where I learned how the AP-ROP starts, and this starts within 2 to 3 weeks. And Ajay also showed that case at 30 weeks. 27 weeks born, 30 weeks he came to you with AP-ROP. So it starts very early, but people miss this stage. And then they see it at 4 or 5 weeks, and then they say, it suddenly became rush disease. It doesn't suddenly become something. It starts very subtly, but you can miss it. I will show you one more picture of this subtle change. But here's another case. This case was, I was on leave and my fellow was screening and he called me and said, madam, there's this case with only one eye ROP. And it's a very unusual ROP because there's no ROP at posterior pole. I challenged him. I said, look, I have not seen a ROP where there's no change at the posterior pole. Always it will be there, always. And when I looked at it, this was actually a neonatal coats. And this was the first time I had seen a neonatal coats. You can see it had telangiectatic vessels. And the coats also has a VEGF component, and I was not sure what will happen. This was a premature baby with Coats disease. We lasered it, and after 8 weeks, it had new areas of Coats, so which is very unusual. So I don't know how many of you have seen a Coats disease in a newborn. I was trying to see in literature. It's not very well documented. So we hope we can publish this. The Coats also worsens in the first few weeks if it is a premature baby, and so you need to be aware and look at new areas developing Coats disease. And at that stage, they won't have Hardeg's dates because that comes up only later. And this is again to show, you can almost see it like, like you see in the trees. Those who worked on trees, I'm from Kashmir, when you cut the tree, from the ring size, you can make out whether it was a good season or it was a bad season. In good season, they have thick bark. In the thin season, they have a small bark. So you can see here this child is doing well. It is dichotomously branching, and then suddenly something has happened systemically, whether it was bad oxygen, whether he got pneumonia or he got anemia, and then suddenly the vessels have started looping. So this is a zone 2 posterior early APROP, and already actually flat new vessels have started here nasally, and this is another thing which we may miss. And we may not see it. Dr. Azad has described hemorrhages occurring after RETCAM, and we've also seen this. If you do RETCAM and they release the camera, and this can also happen during laser, you can see hemorrhages developing in areas which you didn't think that this was treatable ROP. But if you see this, and you will know that, as Parijat also showed, that if you had angiogram, you could detect that this is actually active ROP. If the baby is on oxygen, when you examine the baby, you can miss early stages of ROP. So you have to be very careful and not look at just the vessels and dilatation, but you look at the tortuosity. The tortuosity is not affected by oxygen, but the dilatation is affected by oxygen, and you can miss it if you examine when the child was still on oxygen. So here again, I'm just showing this baby has come late, and we have done laser. And within 3 days, the disease has gone in that area. But here it's still persisting. And when you laser this, you need to laser this whole area. Don't laser just this, because the avascular retina is here, and that is why it is not going. So you can actually detect where it was. And your final result should be something like what is shown in the inset. Use of Avastin, initially we started it as rescue therapy. So people say, if there is traction, don't use it. But this was one baby, I've done laser. There was large hemorrhage, and there was little traction. And I was just trying to imagine, what's the physics of this traction? Will it worsen? Even if it contracts, how much it will worsen? So I went ahead and gave the dose, and you can see the traction did not worsen. Actually, it did very beautifully. So when you're talking of, surgery or whether the disease is going to progress or not, look at the vitreoretinal relationship. So Michael Tracy says that, if the traction is more than 4 clock hours, it is more circumferential or anterior-posterior, then it's likely to progress. So you can make a three-dimensional picture of the vitreous retina, and then you can have some idea, is this traction going to progress? If it is going to progress, you operate earlier rather than later. And this is one of this case I saw, 5 days after the BEAT ROP study, and this patient has come with this severe disease. So I'm very happy I can go ahead and inject. And this was published when we injected, the patient developed choroidal detachment, choroidal infarcts. The next day the patient, I was planning to do laser the next day, patient came at 7 p.m. I gave Avastin. And this is what happened. And so yes, it's not all that simple. VEGF is required for choroidal development, and it can cause very severe choroidal detachment. Today this baby's right eye is blind. They develop choroidal rupture, they develop retinal ruptures. I didn't know what to do, so I just gave topical steroids and everything regressed. But after 2 weeks, it came back, and then we did laser. So this case is already published, and there are other reports of choroidal rupture and choroidal changes in various clinical trials and in various studies. So this is something we need to be aware. This is one of my first lasers. So as we said, sometimes we get these patients, so you can see it's a very badly done laser, so I have to learn some more. And then I learned, okay, I need to do laser here. So, but when there is an elevated ridge, as we said, there will be posterior area. So I was describing, so these all are posterior avascular retina, but don't laser here, laser here, and then more important is to cover the anterior part and not to miss that. Don't try to do barrage and leave this alone. Everything needs to be lasered. This was again a very rare complication. During laser by my fellow, the child developed central retinal vein occlusion. Come on, my heart stopped. I said, like, CRVO occurred. What happened? Did you press the eye too much? Did you put too much of phenylephrine? Was the baby dehydrated? How could a baby, I've done thousands of lasers, they don't get CRVO. And then we evaluated this child had severe protein C and S deficiency, and then we came to know that sepsis can lead to protein C S deficiency, and they get very severe hemorrhages. So you may need to, treat that. We gave Avastin, it regressed, and then we did another laser, and after a few weeks, the protein CS levels have come back. So ROP in big babies, recently somebody sent me a case, look at this ROP in 3 kg baby. This is not ROP. This is FEVR. The mother is blind, So this can really mimic ROP. But too few things you can see that there is no plus. Then vessels, new vessels, there is a lot of avascular retina. The avascular retina doesn't show any regression, and they don't have plus. But you can have a plus type of FEVR also in newborns. So if you see FEVR in term baby or near term baby and borderline cases, always examine the parents. In 20% cases, the parents may show a change. You can also see other diseases during screening. So this patient was, thought to have ROP, but was actually having viral retinitis. And I have, seen these patients. During screening, you see retina is normal, and then you see viral retinitis. So I will stop here. And only the last thing I want to say, if you do surgeries, you will have anisometropia if you operate only one eye, and you must do very frequent refractions. You can see here, the refraction changes very fast in the operated eye, and you may miss this when you do lens sparing vitrectomy.
Thank you very much, Subhadra.